I'm Thomas Baldrick. This is Thrombosis.TV coverage of the 2015 ISTH conference in Toronto. Joining us now, Dr. Marc Carrier from the University of Ottawa, and here to talk about guidelines for cancer patients in hospitals. Thank you, sir, for coming by.
Thank you for having me.
So let's describe the acutely medically ill population, specifically patients with cancer, and their risk of thrombosis.
Right, so cancer patients often have to be admitted to hospital for a variety of different reasons. Sometimes it's for chemotherapy deliverance, sometimes for complication from chemotherapy. Infection, for example, is a frequent admitting diagnosis. And when they're admitted to hospital, these patients are at high risk of having venous thrombosis as a complication of their hospitalization. So current recommendations are saying that they should probably be on thromboprophylaxis. However, they're also at high risk of bleeding because they have high risk features for bleeding as well. And therefore the risk-benefit ratio of thromboprophylaxis is not really well understood. And we aim to look at 3 different Canadian centers and see what was the prevalence of thromboprophylaxis use, but more importantly, what's the risk of recurrent VTE and what's the risk of bleeding in that patient population.
And what did you find?
So unfortunately, we found that we're not following guidelines very carefully because only about 30 to 35 patients that were deemed to be appropriately receiving thromboprophylaxis received it. So there's a lot of room for improvement for sure. In those that received thromboprophylaxis, we saw that the risk of major bleeding is small, and therefore that's reassuring for clinicians and then should be helpful to show clinicians that using properly doses of thromboprophylaxis is not increasing the risk of bleeding. And on the flip side, for those that did receive thromboprophylaxis, there was not a big difference between the group that received it and not received it. And therefore maybe because cancer patients are so hypercoagulable, maybe there's room to increase the dose of thromboprophylaxis. So we did this study in order to try to delineate the different parameters to do a bigger trial on thromboprophylaxis in medically ill hospitalized cancer patients.
What about a focus on event rates?
So the event rates for VTE during hospitalization was high, but not different between cancer patients that received thromboprophylaxis or not, leading or creating the hypothesis that maybe we should use bigger doses of thromboprophylaxis. So for example, instead of using enoxaparin 40, we should use something higher. And more importantly, the risk of major bleeding in patients receiving pharmacological thromboprophylaxis during the hospitalization was not high. So that's reassuring for clinicians.
So what might you do next with this?
Right, so we did all this to prepare a next randomized controlled trial where patients with cancer admitted to hospital for complication of their chemotherapy or any other reasons will be randomized to the standard doses of thromboprophylaxis or a bigger doses of thromboprophylaxis and then followed over time to try to see if we can tailor the risk-benefit ratio a little bit more precisely for this high-risk population.
Keep us posted, Dr. Carrier, would you?
We will.
Thanks for joining us.
Thank you for having me.